Imagine going to a doctor because you are depressed or anxious, or hearing voices or experiencing emotions so overwhelming that your family no longer knows how to help you. And imagine the doctor telling you there is a new treatment. It does not require years of therapy. It does not require medication. Instead, the doctor wants to permanently alter the connections inside the front of your brain. For a period in the 20th century, this was not considered some underground experiment. It was medicine. It was performed in hospitals. It was discussed at medical conferences. Thousands of patients underwent it. And the man whose work helped start the movement would eventually receive one of the most prestigious awards in science. Today, we remember the procedure by one disturbing name, the lobotomy. But the strangest part of this story is not simply that lobotomies happened, it is how quickly intelligent doctors convinced themselves that they worked. To understand that, you have to imagine psychiatry before modern psychiatric medicine. In the early 20th century, doctors were facing an enormous problem. Mental hospitals were filling with people suffering from schizophrenia, severe depression, psychosis, mania, and other conditions that physicians had very few effective ways to treat. Some patients remained institutionalized for years. Others spent most of their lives there. Doctors could restrain patients, they could sedate them, they experimented with treatments such as insulin coma therapy and electroconvulsive therapy, but for many severe psychiatric illnesses, there was no reliable medication that could simply reduce hallucinations, delusions, or extreme agitation. Hospitals became overcrowded, families became desperate, doctors became desperate too, and desperation has a strange effect on medicine. When almost nothing seems to work, even a dangerous idea can begin to look reasonable. In the 1930s, Portuguese neurologist António Egas Moniz began thinking about the frontal regions of the brain. The frontal lobes are deeply involved in things like planning, decision-making, emotion, motivation, and personality. Moniz believed that some severe psychiatric disorders might involve abnormal patterns of connections in the brain. His idea was radical. Instead of trying to change a person's thoughts from the outside, perhaps doctors could change the circuits producing those thoughts from the inside. In 1935, working with surgeon Almeida Lima, Moniz began performing an operation known as a prefrontal leucotomy. The procedure damaged connections involving the frontal areas of the brain, and afterwards something interesting sometimes happened. Some patients who had been extremely distressed or agitated became calmer, to doctors searching desperately for treatments that looked promising. But there was a problem hidden inside the word calmer. A patient becoming quieter does not necessarily mean that the illness has been cured. If you reduce someone's emotional intensity by damaging the systems that help produce emotion, motivation, judgment, and personality, the result might look like improvement from the outside. But what has actually happened to the person? At the time, that distinction was not always easy to measure. Psychiatry did not have the controlled clinical trials, standardized outcome measures, imaging technologies, and ethical oversight that modern researchers expect. Early reports generated excitement, the procedure spread, and in 1949, Moniz was awarded half of the Nobel Prize in Physiology or Medicine for what the Nobel Committee described as the therapeutic value of leucotomy in certain psychoses. Think about how powerful that endorsement would have been. This was not being treated like fringe medicine. It had received a Nobel Prize, and across the Atlantic, one American doctor was about to become its most famous promoter. His name was Walter Freeman. Freeman was a neurologist, not a neurosurgeon. Early on, he worked with neurosurgeon James Watts. Together, they developed and promoted their own form of prefrontal lobotomy in the United States. The standard operation still involved accessing the brain surgically. That created an obstacle for Freeman. If lobotomy required an operating room and a trained neurosurgeon, it could never reach the enormous number of psychiatric patients he believed could benefit. Freeman wanted something faster, simpler, something that could be performed far more widely, and that desire led to the procedure that would make the word lobotomy infamous. The transorbital lobotomy. Most people know it by another name, the ice pick lobotomy. The nickname was frighteningly appropriate. Freeman's early transorbital instrument was inspired by an ice pick-like design, although purpose-built surgical instruments called orbitoclasts were later used. Instead of opening the skull in the conventional way, the instrument entered through the area above the eye and passed through the thin bone of the eye socket into the frontal region of the brain. The instrument was then manipulated to disrupt white matter connections. Freeman believed this made lobotomy faster and more accessible. The procedure could be performed without the kind of traditional neurosurgical operation that had previously been required. And Freeman did not quietly practice this technique in one hospital. He promoted it, he traveled, he demonstrated it, he spoke to the press, he photographed patients. He became one of the most recognizable advocates of psychosurgery in America. Over the course of his career, Freeman personally performed thousands of lobotomy procedures, and for a time, the idea spread far beyond him. To understand why, it is important not to imagine every doctor involved as a cartoon villain. Many doctors genuinely believed they were helping people who had no other options. Some patients were suffering profoundly, some were violent or severely psychotic, some had spent years inside institutions, and there were cases in which families or doctors reported meaningful improvements after surgery. That is part of what makes this history uncomfortable. Lobotomy did sometimes change the symptoms people were experiencing. The problem was that it could change much more than the symptoms. Patients could become passive, emotionally blunted, apathetic, unable to plan, unable to work independently. Their judgment could change, their personalities could change. Some experienced seizures and serious neurological complications, some died, and some survived while losing parts of themselves that could never be restored. A successful lobotomy could therefore mean very different things depending on who was defining success. Imagine a patient who screamed constantly, fought with hospital staff, or experienced terrifying delusions. After surgery, that person might sit quietly for hours. From the perspective of an overcrowded institution, the patient was easier to manage. From the perspective of a medical chart, certain symptoms might appear reduced, but if that same person also lost initiative, emotional depth, or the ability to function independently, was that recovery, or had doctors simply exchanged one kind of suffering for another? That question became increasingly difficult to ignore, and the more lobotomies were performed, the more disturbing outcomes accumulated. The procedure was also used across a wide range of psychiatric diagnoses: schizophrenia, severe depression, obsessive symptoms, chronic anxiety, behavioral problems. The boundaries of what might justify permanently altering someone's brain could become dangerously wide. This was especially troubling because many psychiatric patients had limited power over decisions being made about them. Consent standards were not what they are today. Families, physicians, and institutions could have enormous influence over whether a person underwent treatment. Walter Freeman remained convinced for years that the operation had value. He continued traveling across the United States, performing and promoting transorbital lobotomies. But medicine around him was beginning to change. In the early 1950s, a drug called chlorpromazine entered psychiatry. For doctors treating psychosis, it was revolutionary. For the first time, physicians had a medication that could reduce severe symptoms such as hallucinations, delusions, and agitation in many patients without surgically destroying brain tissue. It was not a perfect drug. It had side effects. It did not work for everyone. But the entire calculation had changed. Before drugs like chlorpromazine, doctors facing a severely ill patient might see lobotomy as one of the few options left. Now there was an alternative. At the same time, criticism of lobotomy was growing. Doctors were becoming increasingly uncomfortable with its complications and inconsistent outcomes. Neurosurgeons had criticized Freeman's simplified transorbital technique. Public attitudes were changing, and the medical world was beginning to confront a painful question: how had something so destructive become so normal? By the late 1950s, lobotomy was rapidly losing its place in mainstream psychiatric treatment. Walter Freeman's reputation deteriorated. The procedure that had once been described as revolutionary became a symbol of some of the darkest mistakes in modern medicine. But there is an important detail here. Brain surgery for psychiatric illness did not disappear completely. Modern psychosurgery and neuromodulation are completely different from Freeman's crude transorbital procedures today. Rare cases of severe treatment-resistant psychiatric illness can involve highly targeted interventions performed under strict medical and ethical oversight. The lesson of the lobotomy is not that touching the brain is automatically barbaric. The lesson is about certainty. Because Freeman and other doctors were not operating with the goal of hurting people, they believed they had discovered a way to relieve suffering. That belief became so powerful that it could make devastating side effects look acceptable. A quieter patient could be called an improved patient. A more manageable person could be called a recovered person. And once a treatment gained enough momentum, each successful-looking case made the next operation easier to justify. That may be the most frightening part of this story. Lobotomies were not performed in some distant prehistoric world where nobody understood medicine. They reached their height in the 20th century. There were automobiles outside the hospitals, radios in people's homes, airplanes crossing oceans, scientists were developing antibiotics and unlocking the structure of the atom, and at the same time, doctors were intentionally destroying connections inside people's brains because the best medical knowledge available to them suggested that doing so might help. That should make us uncomfortable, not because modern doctors are secretly doing the same thing, but because every generation tends to believe that it finally understands the human body. People in the future may look back at some things we do today and wonder how they were ever considered normal. The story of the lobotomy is therefore bigger than Walter Freeman. It is bigger than the ice pick. It is bigger than one horrifying chapter in psychiatry. It is a reminder that medicine advances not only by discovering new treatments, it advances by learning how to question them, by demanding evidence, by measuring what happens years later, not just days later, by asking whether a treatment improves the patient's life rather than simply making the patient easier to manage, and by remembering that behind every medical statistic is a person who has to live with the result. For thousands of lobotomy patients, that result could never be undone. The procedure was supposed to free people from the illnesses trapped inside their minds. But for some, the price of making the illness quieter was losing part of the person along with it. And that is why the history of the lobotomy remains one of the most disturbing warnings medicine has ever given us. Sometimes the most dangerous treatments are not the ones everyone knows are dangerous. They are the ones an entire generation becomes convinced are helping.